Hi everyone, in this video we are going to discuss about amalgam cracks and whether to treat or not to treat these teeth. It is a very controversial topic because we see this day in and day out in our practices, especially in UK because of the historically amalgams been used extensively in UK, and that's why we see this sort of amalgam cracks all the time. And what I've seen in my experience that it is irrespective of the size of the fillings. So if this if restoration is even small, sometimes the teeth can develop a lot of cracks because of amalgam, and of course due to occlusal load on those teeth. However, when we see these cases, I always have a chat with patients. So I would take the photographs, show it to patient, and what I will tell patient that we don't know whether the crack is definitely caused by amalgam, although we have a fair idea that most likely it is due to amalgam. We do not know that it is 100% due to amalgam. I don't know whether the tooth is going to completely fracture or not, and if it is going to happen, when it is going to happen. Because in past, when I was young and naive, I had, used to tell patient that this tooth is going to fracture, it won't last long. And I see patient 10 years later and the tooth hasn't fractured, tooth is fine. So I tend to tell patient upfront that, look, we cannot predict when these teeth are going to fracture. It is not possible to predict that it's going to fracture a certain time or date or certain month. It's going to last you a year, 2 years, 3 years, 4 years. So if we are treating this, it is more preventative treatment rather than treatment of a disease. Although in my eyes, cracking or crack line is almost like a disease because, it's not functional. You've done something and that because of that, it has cracked the tooth. So structurally, tooth is failing. Mechanically is failing. So you need to communicate this with patient. The other thing I tell patient that I don't know when it fractures, whether it will fracture catastrophically, such as, this patient, or it will fracture such as this patient as well, catastrophically, where it's a vertical fracture. Again, in this patient, small amalgam, we don't know, it's a 7. So it could be, and you can see massive faceting on palatal aspect of that tooth. So we don't know what is the reason the tooth has snapped in half, whether it's amalgam or is it just the occlusion is the cause of it. But if it fractures like that, then obviously you end up losing the tooth. But if it fractures just a chipping of the cusp, then you can still restore it. And you need to tell patient that you don't know. And over the times, I have realized that accepting the fact that you don't know, it's the best policy when you're communicating patient, then try and elude patient that you know everything. And, I'm sure you all do that, but the more and more experience you get, I tend to tell patient, even when you're doing treatment, surgical treatment, I tell patients that, look, I've done thousands of implants, but it's very difficult to guarantee 100% that the implant will integrate. If someone gives you guarantee of 100%, that means that the dentist hasn't placed enough implants. So you need to be upfront and honest with patient, and most of the time, 99% of the patient would understand. If someone doesn't understand, then trust me, you don't want to treat that patient because their expectation may be very unrealistic. So I tell patient that, look, I don't know if the tooth is going to fracture, how it will fracture. But what I have noticed is that when I'm removing this restoration, I see that the crack line is much worse than what it looks from outside. Because as you would have seen that remove this amalgam where you just see mesial or distal crack line, and then you see the crack line just going through and through. And now the question is whether are you going to chase this crack line as long as you can until it disappears, or you're going to leave it as it is. Again, it's a controversial topic. I tend to not chase beyond the gum line because it's just no point in making it subgingival restoration. You need to tell patient that it's compromised. So I always give patient an analogy of a cricket bat. So if you have a cricket bat which is splitted, and if you still want to carry on using that bat for whatever reason, then what you can do is you can try and put a tape around it, try and hold it together and start using it. But you have to be a bit gentle, but you cannot heal that bat because it's not active, it's not biologically active substance. So once it's cracked, the tooth will always stay cracked. We're just trying to confine that crack so that it doesn't spread any further. And there are lots of papers come out with endodontically treated teeth and treatment of these cracked teeth, such as Oliveri or Optum in 2008. He assessed these cracked teeth. It was only 40 teeth and for 7 years, but still he assessed that he put some composite on the teeth to sort of seal the cracks, and some of the other teeth he didn't. And he saw the 6% failure rate when he didn't, and 0% when he did do some sort of a bonding or overlay. So I am biased, and I feel that all the cracked teeth should be proactively treated, of course, with patient's consent in mind. So the 3 tips is that tip number 1 is, yes, I would treat cracked teeth when the patient has amalgam or any reason why they are cracking, because you wouldn't leave those teeth as it is. You do need to also communicate with patient that by removing this restoration, sometimes it can happen that sometimes those restorations just about holding the cracked tooth, and sometimes if you remove the restoration, the tooth falls apart. It doesn't happen catastrophically. Usually the cusp chips or something like that, but you need to warn patient. You need to warn patient that they may need root canal treatment if the crack is deep and there is a caries. Many times cracks are associated with caries because of micro leakage. So you need to communicate that with patient. Communication is key when you're making patient understand what you're doing. Assess symptoms. If the tooth is symptomatic, I would not put a definitive restoration. So if cracked tooth is symptomatic, I tend to give them full coverage restoration, most likely crown, and I would give patient provisional crown, a nicely made provisional crown, and leave them for a couple of months. Make sure that patient's fine with it, there is no issue, patient doesn't need a root canal treatment, and then change it to definitive, keeping in mind that tooth was symptomatic before. Patient may need a root canal in future. If the tooth is not symptomatic, then I am completely okay to do an onlay versus full coverage crown on cracked teeth. And I've treated thousands of teeth like this over 12 years, and I have very minimal failure. And most of the failure is because patient has vertical fracture in one tooth over thousands of onlays I've done, and another teeth, some of the teeth became symptomatic, which can happen with even crown. So I'm very comfortable providing patient onlay rather than a crown, because onlays, as we know, is much more conservative than crown. However, it's a fine balance when to choose to do crown or an onlay when you're treating cracked tooth. So if the crack is quite wide and you can see spreading, then crown may be much more ideal treatment modality than an onlay, just to cover the tooth from all around. So you need to select depending on the size of the crack and the opening of the crack, whether you're going to do onlay or a crown. So I hope you found this video useful. If you have, please share with your colleagues, friends. If you have any questions, please contact me on social media or go to my website www.drdevangpatel.com. In the next video, I am going to discuss about deep marginal elevation and some of the benefits and the procedural steps of deep marginal elevation.